Dr. Lopamudra will be speaking on my experience with Tanito Micro Hook. She is a consultant at Chaitanya Eye Hospital, Trivandrum.
Thank you, ma'am. Ma'am was one of the mentor in Arvind. So I will be talking on Tanito Micro Hook trabeculotomy. No financial disclosure. The current version of trabeculotomy has evolved from ab external to the ab internal technique, which fulfills the condition of minimally invasive glaucoma surgery. So the ab internal trabeculotomy can be done by various methods, as already discussed, by KDB blade, Tanito Micro Hook, GAT, trabectome, and bang. So coming to the base choice concept, among the MIGS procedures, it should have a lowest IOP, highest success rate, lowest complication rate, and it should be cost effective, and it should give best vision, and so on. So among the incisional TM based procedure, though GAT has a very promising outcome, but it has a stiff learning curve, and the post-operative hyphema is common. Coming to the KDB blade, it also gives a very meaningful IOP reduction, but it is expensive. Same is with trabectome. And next is bang. Bang is done with a bend 25 gauge needle, and the safety profile, the efficacy is doubtful. So why Tanito Micro Hook trabeculotomy? The first day of our cataract surgery, we are very much used to with this Sinskey hook, and the Tanito Micro Hook is very similar to a Sinskey hook with a specialized tip. The Tanito Micro Hook is very easy to learn, it is efficacious, it is economic, and it has a very good safety profile. And if the surgeon wants, he can do a more wider extent of trabeculotomy. So it can be started as a first MIGS procedure by the beginners. So again, the question being currently debated whether to preserve or remove all the trabecular meshwork. So sparing some of the TM lens canal complex may provide for another TM based procedure in future. So a more limited trabeculotomy can give a balance between the IOP reduction and the preservation of the TM tissue. This Tanito Micro Hook is a specially designed micro hook with a single blade, oblique tip surface with a circular edge to cleave the trabecular meshwork and the inner wall of the Slem's canal. It comes in 3 models. The straight one is to approach the nasal angle, and the angle left and angle right, you can approach both nasal and temporal angle. If you compare the Tanito Micro Hook with the rest of the instrument, it is very thin and slender, and the tip of the hook is much smaller. So the anterior chamber manipulation is being easier. It allows the surgeon to assess all the quadrants of the TM if he wants. The another advantage is it is not disposable. It can be reused for countless times after sterilization. Again, if you compare the Tanito Micro Hook with rest of the procedures, it gives the opportunity to approach half to 2/3 circumference of the trabecular meshwork apart from gap, as you can see here. So this is the video. Here you can see this is the angle left and angle right hook. The angle left you can approach the superior-nasal angle, and the angle right you can approach the inferior-nasal angle. I usually do after the completion of the emulsification. So the anterior chamber is distended with the high molecular weight viscoelastic, and the Swan-Jacob gonio lens is used to focus the angle structures. And the Tanito Micro Hook is introduced through the 2.8 clear corneal phaco incision, and the tip is inserted into the trabecular meshwork, and it is moved circumferentially over the desired clock hours to excise the TM and the inner wall of the Slem's canal. And you can see here the white strip behind that represent the back wall of the Slem's canal. I used to prefer to do the superior-nasal angle first, then the inferior-nasal angle. And again, you can see that is a blood reflex into the anterior chamber, and the anterior chamber is washed, and the wounds are hydrated to form a watertight chamber. And after insertion, the tip of the hook, the depth can be monitored by looking at the tip of the hook. If you are in a deeper plane, you won't able to see the tip. And if you are in an adequate plane, and then you feel very minimal resistance while moving the trabecular hook. And you can see that is a blood reflux from the angle. And post-operatively, we give antibiotic for 2 weeks and steroid drops tapering dose for 6 weeks and non-steroidal antibiotic for 8 weeks and pilocarpine for 6 weeks depending upon the surgeon's choice. In our center, we have almost done 36 cases who has completed 3 months of post-op with mild to moderate open-angle glaucoma, which was medically controlled, and the baseline IOP was 13.19 with anti-glaucoma medication, and the number of anti-glaucoma medication was 1.33. The preoperative intraocular pressure was 13.19 with anti-glaucoma medication. At 3 months post-operatively, it dropped to 11.31 and most of them were AGM free. And the preoperative number of AGM was 1.33, and at 3 months post-operatively, 33 patients were AGM free and only 3 patients were on AGM. And the common complications were hyphema, stromal edema, IOP spikes. And in my initial cases, I used to get there is a localized edema with bullae near the section. It is because of while taking out the hook, I used to get small DM strips. And all eyes has got a best corrected visual acuity of more than 6/9 at 1 month post-operatively. As you can, this is the post-gonio picture at 1 month post-op. And you can see here there is a trabeculotomy cleft in the nasal angle. And same thing is shown here in the SOCT. As I have already told, I have some few cases initial cases I have small DM strips while taking out the hook. If the tip of the hook is up, then I used to get like this kind of DM strips. So there is a study by Tanito et al. Where he described the effectiveness and safety of combined cataract surgery and micro ab interno trabeculotomy in 68 patients. The mean preoperative IOP dropped from 16.4 to 11.8 and the number of AGM 2.4 to 2.1, and the most postoperative complication was hyphema. A study by Sasidharan et al., which was published in IJO, the short-term outcome of Tanito Micro Hook trabeculotomy, which was combined with phacoemulsification in open-angle glaucoma in 30 patients. All eyes has a best corrected visual acuity of more than 6/9, and the mean IOP was reduced from 23.57 to 17.33. But here none of the patient was on AGM, and the post and IOP spikes, edema, hyphema, and IOP spikes. So to conclude, the Tanito Micro Hook trabeculotomy is a safe and efficacious in mild to moderate open-angle glaucoma with relatively minimal complication. There is a moderate reduction of intraocular pressure with reduction of the anti-glaucoma medication burden with rare vision-threatening complication. It is cost-effective alternative to many TM-based glaucoma procedure because the hook is not disposable and it can be reused for countless times. So combining with cataract surgery is a valuable addition to the glaucoma surgical armamentarium in developing countries. Thank you.